there is reduced uptake of oxygen, and then you have cyanide poisoning, or when the cells are dead, as maybe some kind of problem in the whole body. So sometimes in brain dead patient also we see this one, because brain is not consuming oxygen, brain is dead, and then the uptake of oxygen is reduced, and the mixiness goes up, because what comes back into the heart is actually after utilization from the peripheral tissue. So in a brain dead patient, or say a central nervous cyanide poisoning, the cells are not utilizing oxygen, and sepsis you have cytotoxicity, and so you have high mixinous saturation. So most people do not rely on mixiness, because they say in sepsis it's not reliable, so they don't even measure it. I have seen in our country also, especially even in some of the main hospitals in Colombo, I have seen in the past, some of the senior registrars, and I talk to them, they say we don't monitor mixiness. I ask them why, because it's not reliable. The latest evidence says it's not reliable. It is true, it's not reliable, but imagine, like my patient I saw, when the mixiness is 30 and you don't know about that one, because your arterial one is good. Arterial one is only oxygenation. Your saturation is 100% from the artery, but the cardiac output is very low, oxygen level is very low. Patient may be dying unless you check the mixiness, you don't know, or the central venous, you don't know. So it's important to check even in sepsis. If it is high, maybe it's not that reliable. But if you see a reducing value, that is a significant one. So remember to check when you become, when you do manage ICU patients, septic patients, try to check even if it is not helpful. But if you keep checking, and if you see it is coming down, and that's a significant finding. And so this will come down when there is lack of oxygen delivery, maybe hemorrhage, shock, any high demand, any sepsis. Once again, it can actually come down in sepsis also. Usually it comes down, but in high, it can be high also. And rarely it can be increased uptake, but we don't see them clinically. It can happen in, say, thyrotoxic crisis or something like that, or maybe malignant hyperthermia, somewhere where the tissues are consuming a lot of oxygen. Then you can have a low mixiness over there. So these are some examples of high SvO2. So when you give neuromuscular blockers, the muscles are not actively contracting, and even the baseline contraction stops, so that it doesn't consume a lot of oxygen, and your oxygen mixiness rises. And hypothermia, that metabolism comes down, and then things like that. So there are so many reasons, may be important for the MCQs. So the sorry about this distortion, because this new device, the PowerPoint presentation has distorted. And so I told you the first response is increase in fast, and first response increase cardiac output. So remember that one for the rest of your life. Oxygen delivery, cardiac output is important, and it is almost all the ICUs. I mean, people forget this fact, and then they only look at the saturation and try to do everything to improve saturation. Saturation improvement is important, but you should not reduce the cardiac output. And then the second one is increase in oxygen extraction ratio. That is how the tissues extract more oxygen. So it helps. So 2-3 dpg. There are so many other mechanisms. The shift in the curve to the right, releasing more oxygen to the tissues. They extract more oxygen as a second mechanism. And then if it's also impossible, you go to anaerobic metabolism. So when you have a problem, then you have to think of where the problem is. Is the lung providing enough oxygen to the bloodstream, or whether you are giving enough blood flow to the tissues? And how about the extraction ratio? These are the things we have to think. And basically, it's the lung and the blood flow. Blood flow is the most important thing, which you should never forget about. And then So this is one example which I have shown you, and here I have calculated. So the patient, two patients with two scenarios. One having hemoglobin of 10, saturation of 87, PO2 55, cardiac output to 6 liters. So when you calculate, they deliver 700 ml because saturation 88, but the cardiac output is 6 liters. So they deliver 700, not 1000, but still it is enough to save the patient life. Hemoglobin is slightly low, saturation is low, but the cardiac output is good. But in this example, second example, hemoglobin is the same, saturation is 100%. PO2 is 150, but the cardiac output is low. And if you calculate, and these are scientifically improved, and calculate, you don't deliver enough oxygen for the survivor. Now this patient, both patients having hemoglobin of 10, one is having low saturation, but the cardiac output is good. The other one is having high saturation, but the cardiac output is low. The one with lower saturation is going to die. But it's not the idea to reduce the saturation. So that's not the example I'm showing you. I'm showing you even saturation low, but providing enough cardiac output is the key. If that fact you can remember that I have taught you something today, it's very, very important. So compensation. So if you look at saturation, if you increase 1%, you add about 10 ml of oxygen to the content and per liter. But hemoglobin 1 gram is 69 ml, but cardiac output 1 liter equals 200 ml of oxygen. So the cardiac output is the most important one for the oxygen delivery. So if you have multiple problems, like, patient is in high altitude and having some problem with the lung, at the same time patient is anemic and having heart disease, and then the mixiness can be extremely low and they can die if you have combination of the other problems. So this is the and the other thing I just want you to know about this is a practical one. So this actually shows lung in exercise and tissue one, but I'll just so forget about this this thing. I'll just say forget about the lung. So this is a normal oxygen dissociation curve, and I told you cannot extract more than less than 22 of PaO2 or 32 or some saturation, something like that. And you can't extract when the tissue PO2 is 22 or less, you can't extract. So your maximum extraction, the normal extraction is from 22 5 ml over here, but there is a reserve. But if you shift the curve to the right, in 22, the curve is somewhere over here. So you have additional extraction over here when you shift the curve to the right. That's what the nature is doing. It's shifting the curve to the right so that even at lower PO2, it can still extract. So if you give bicarbonate to a patient just to keep the acidosis under control, but you are actually shifting the curve to the left, and you can't even extract the normal amount. You are losing even this part also. So it's a crime if you do not know what is happening with the patient, and you just try to correct the pH to 7.4 when the patient is having acidosis without correcting the underlying problem. So you just want some people I have seen, they just want a 7.4 pH in the blood gas all the time. So base excess of -5, they give bicarbonate. Bicarbonate is not going to so it will improve the blood gas definitely, because you give bicarbonate and the blood gas will improve. But the problem is not solved. Problem is lack of oxygen delivery. If you're not delivering enough oxygen, the body is trying to shift the curve and extract more oxygen. And you are trying to shift the curve to the opposite side because you want to have blood normal pH. Now, normal blood pH is not what we are interested. But we are interested in tissue pH, but we are not measuring tissue pH. We are taking the blood pH as a surrogate to imagine what is going to happen with the tissues. So whole idea is to correct the tissue pH, but we look at the blood as an indicator because we can't get into the cell. So the idea is not blindly correct the blood pH. There's no point correcting blood pH because if the tissues are getting worse. So bicarbonate should be given if there is a loss of bicarbonate, like in a renal failure, they can't absorb bicarbonate and you're acidotic. You can give bicarbonate because the kidney is losing bicarbonate. But you have normal amount of bicarbonate and then the blood gas shows low bicarbonate because of acidosis, and you correct the acidosis without correcting the underlying problem. So I think best thing is to improve. So if the patient is anemic and septic, best to give blood and provide oxygen, and the acidosis will improve. If the patient is hypovolemic, traumatic hypovolemia, you can give blood. If the patient is diarrhea, dehydration, hypovolemia, you can give fluid, and the acidosis will improve. But you should not blindly correct acidosis with bicarbonate unless you correct the underlying problem. You can sometimes, if the pH is 6.9 or something, it directly affects the heart. Then, of course, you can give bicarbonate to save the heart, but not to correct the pH to 7.4. Never ever correct the pH to 7.4 with bicarbonate. So I hope I taught you some important stuff in your day-to-day practice also. I had to rush through because I was given 3 lectures. I simply can't do everything within these 2 hours. This is what I can do for the moment, but maybe we can arrange another lecture for the this lung mechanics, because I hope you understand. I had to teach all these things, but I don't have enough. This was actually very fast. Some of you might have found it difficult to catch up because I'm going fast, because this 2 hours is not enough to do 3 lectures. Okay, if you have any question, you can ask. I can answer. Do you guys have any questions? Anybody having any questions? Okay, I'll stop the lecture from here. I'll hand over to, because it's 5 o'clock. I'll hand over to, I think Bimal is doing the next lecture. Okay.
Thank you.
Thank you.
Good evening, rather, for you all. Can you hear me?
Yes.
Okay, good. Let me. So I think I have the task of completing ultrasound, Doppler, and laser. And am I talking to 1B preparatory course? Is that correct? Hello?
Yes, sir.
Okay. So let me share my screen.
Sir, cannot see the screen.
Can you see me?
Yes, sir.
Okay. Just hold on. I haven't shared it yet. Just hold on a minute. Can you see now?
Yes, sir.
Yes.
So I'm Dr. Bimal Kudavidanage, consultant anesthetist and intensivist. I used to work in NHSL, now I'm working in England. So I will begin with a laser and then we'll have a couple of minutes break and then go to ultrasound and Doppler physics. All right. So I know you are tired, so I'll try to be brief as possible. So in regards to laser, I can tell that one of my physics viva is on laser, whole 10 minutes. So when I did my, basic part 1 at that time. So it was a new thing at that time. So you need to know the laser. That's important because they can question you. So basically, I generated these questions about laser. So what I think it is important, which is important. So I will use these questions to explain and teach you, right? Or we can have a discussion. And any questions you can ask at the end of the lecture. So basically, what is laser? So laser is an acronym actually. So it stands for light amplification by simulated emission of radiation. Okay. It was theoretically, basis was explained in early 1900, say 1917, where Albert Einstein is the person who explained it first, theoretical basis of laser. And then actual functioning laser was built in 1960s in California by a person called Theodore Mayman. Okay, it's using a ruby crystal with a light. He had a public demonstration of laser when he initially demonstrated. Okay. So then next question is, what are the properties of laser? Why we are bothered about laser? Because it has special properties. Okay. And because of those properties, make it very effective in using it, where we use in so many medical uses as well. And then because of those properties, it makes a danger to us, because it's kind of a spectrum in the radiomagnetic spectrum. So because of that, not all rays are harmful, but this is harmful because of its nature. Okay. So the particles which carry these laser is called photons, and the particular features of laser are, it's a monochromatic. So because it consists of single wavelength, it says it's monochromatic. Because of these features, it has these properties which we can use it. Okay. and these photons are coherent or in phase. The waveform is in phase. Okay, I hope you are familiar with the electromagnetic waveform. So, when we are technical term in phase, that means there's a technical quality of that. Okay, and it's also collimated. What is collimated is it's run parallel to each other, or even it goes very far. It doesn't diverge. So its strength is similar at the beginning as well as very far. That's why it's so dangerous. Okay, so these three features brings its properties where we can use it as a technique to cut, coagulate, or any other uses we have. Okay. So then it comes to what are the components of laser. Okay. So for laser, you need three basic components. One thing is a lacing medium. Okay. So that's a medium which produces this laser, and depending on this lacing medium, different kind of laser we can produce. Okay, so depending on the quality of the lacing medium, we can divide into either solid, which are crystal, or we use glass or crystal for solid lacing media, or it could be liquid like dyes, or it could be gases like carbon dioxide, helium. There are some semiconductor diodes where we'll use lasers as well, okay, in some instances. Then there should be an energy source or pump to supply energy into this lacing medium so that this activation happens, okay, inside a special reactor, okay. So we need to give energy source, either high voltage or a chemical reaction or a diode or some kind of a flash light. We need to induce this energy inside this optical reactor in the lacing medium, okay, to generate this laser, right? Then we need a kind of a special device or optical resonator or optical cavity, which consists of two parallel mirrors either side, okay, with a highly reflective mirror so that everything is get reflected, okay. And in only one side there is a partially reflective mirror, which allows a beam of laser light to escape through, so that we can direct this laser light to our purposes, okay. So it's like a cavity with a parallel walls with highly reflective mirrors, okay. So these are the three components which consist of laser. Okay, so this is a diagrammatic representation, okay. So this whole thing is the reflective mirror, right? And these blue circles are the lacing medium, okay. And this red arrows like thing is the energy which supplies the energy to this lacing medium to activate this laser, okay. And this is the output opening or partial mirror, which we can take out the produced laser in parallel, okay, so that we can direct this light to whatever the purpose we want, okay, depending on what kind of laser we produce, okay. So how this laser is produced in the atomic level, okay. So basically what happens is, now we know in an atom there is a nucleus and a cloud of electrons, okay. So nucleus contains of protons and neutrons, and this cloud of electrons have a varying level of energy levels. Okay. So what happens is now these electrons are circling around in a varying energy levels. If you supply energy, a particular kind of energy to these electrons, it will absorb this energy and it will jump to a higher energy state. Okay. So once these molecules or atoms absorb energy, their electrons jump one level up to a higher energy state. Okay. So charge electrons. So but these are not stabilized on a higher energy level. So it has to come down to a basic energy level where it was. So by doing that, it releases energy. Okay. So this released energy as light particles, which are called photons. Okay. But when it release, it's not in a similar pattern. So it's the energy level of proton which emits is the same, but it's not in same pace. Okay, can you understand what I'm telling? There is a pace discrepancy in it's the same wave or proton, but not in same pace, different paces. Okay, and it scattered all around. So you can't direct it to a particular point. So that's called spontaneous emission. Okay, I'm summarizing again. When atom is given energy, electrons get charged to a higher level, but because of it's unstable, it tends to come back to its basic energy level, releasing photon energy, okay, as here, photon energy. And this release is random and not in pace, different paces, but same energy pockets. Okay. So if this release energy is reflected at the mirror inside this, inside this resonator, optical resonator. So what happens is it gets reflected from this mirror wall. Okay. And energy is directed to other protons which are energized. Okay, so I will show you a diagram. So this is what happened. So this is the lacing medium inside this resonator. Okay, and then it is given energy, and these red dots are high energized particles or atoms, which releases random photons or energy and go back to its stable level. And this energy is reflected back to the lacing medium by this resonator, optical resonator, so that these energies directed towards these energized atoms. Okay. So what will happen is these get double stimulated. Okay. So these get double stimulated. So first thing is random energy release is spontaneous emission. And then what happened is that this reflected onto charge atoms, and there is a further collision and release in energy from excited atoms in much more higher level. Okay, so it releases two protons. Photons is the energy pockets. Okay, but when it releases at this time, because energized atoms receive energy which releases energized photons which are in pace and in same identical direction and which are polarized. Okay, this is called simulated emission. The first thing is random emission or spontaneous emission, and this second one is called stimulated emission. Okay, so this is called this release photons are called laser, right? Because of that amplification, right? Because it has characteristics as identical direction, pace, and polarization. Okay. But the thing is, you need to, if you want to get continuous supply of these photons, energized photons, you need to have a stimulated atoms inside your lacing medium. So you need to supply stimulated atoms inside the lacing medium. That's called population inversion. So you continuously supply energized atoms inside the lacing medium so that it gets released, energy is released, reflected back on themselves, and these are hit by energized atoms, which tend to release this tend to release two protons in identical direction, pace, and polarization. Okay. So what happens is once it is released like this, so this is the increasing stimulation, and then lots of high energy is released, which are in pace and depolarization and in the same direction, and which is directed through this partial reflecting mirror. So there is a one direction laser light is emitted through this. Or laser beam is emitted through this optical resonator. Okay, so that's what happened when you generate this laser beam. So you need to get this laser beam to be useful. To direct, you need to direct this laser beam to your purpose. So what it does is, if it is a if it is a visible light laser can be visible or invisible because it tends to be in a visible range as well as ultraviolet and infrared range. Okay, so if it is a visible range, you can use a fiber optic medium to direct this laser beam to a single point so that you can direct this laser energy to that point to use your purpose, say for burn, coagulation, cutting, or whatever the thing, you can do it when you direct this laser beam to a single point. So to do that, if it is a visible light beam, you can use a fiber optic system to direct this. But if it is infrared one, you can use a series of mirrors to direct this to a particular point. Okay, I hope you can understand what I'm telling you. Okay, so what are medical lasers? There are two types of medical lasers we use. One is continuous wave and the other one is pulse wave. Okay, and it is measured as a power in watts. Okay, and if it's a pulse wave, it can be measured as energy in joules. Okay, so irradiance is a power density. So how much power per unit area of laser? The higher the power density, higher the power of your laser. Okay, and fluence is the energy density, which is irradiance post time. Okay, the time factor is also there. Can you calculate that? Can you get mic, please? So what happens is when you direct laser, either visible or invisible, to a point, and in a medical usage to a tissue, it either can be transmitted or reflected, scattered or absorbed. So those are the things which can happen. Okay. So use as a medical use, we need the tissue needs to absorb this. Okay. So if it is to be used, this tissue needs to absorb this laser kind. So it depends on which tissue we are attacking, which type of laser we are using. Okay. And the type of laser will depend on the wavelength of your laser. So laser light is absorbed by the tissue and it can be biological. So most of the time, water inside these biological cells absorb infrared radiation light, or hemoglobin can absorb visible light in laser. Okay. So what determines this absorption proportion? It's determined by the wavelength, and the other thing which determines the wavelength is the depth of penetration of laser. Okay. If you have a lower wavelength or high frequency, depth of penetration is lower wavelength lasers cannot penetrate to a deeper tissue, so it has to be used in superficial, like skin lesions or cornea, like that. Okay, you can't reach deeper tissues to coagulate or cut if you have a lower wavelength of laser. Okay, so this is the spectrum of laser. So wavelength in a x-axis, right, and in nanometers. So this is ultrasound, ultraviolet range. Okay, then argon laser, 500 nanometers. Okay, and then it comes to infrared range. Okay, YAG laser, and then the carbon dioxide laser is here. It's about 10,000 nanometers. Okay, so large wavelength is very large. Okay, so the frequency is low. So these are the examples of medical lasers what we use. So carbon dioxide laser, we said wavelength is very high, so probably the frequency is low. Because of that, you can penetrate through. Okay, so it can be used as a laser scalpel, right? And it's a gas. The laser medium is gas. The other hand, YAG laser, solid. Okay, so used to ablate tissues, and it's kind of a relatively medium or lower range, lower to medium range wavelength. Okay. Then argon laser, again a gas medium. Okay. So 500 nanometers, right? And it's used in retinal surgeries. Okay. And birthmark removal and all that can be used. So there are liquid lasers as well. So all three medium, solid, liquid, and gas. All three types of lasing medium can be used to generate lasers. Okay, they can ask you a MCQ. Okay, so this liquid can also be used to removal of birthmark or vascular skin lesions, right? Because its wavelength is around 400 to 600 nanometers. Short wavelength with high frequency cannot penetrate. Okay. Then, because of these dangerous properties, but there are useful properties as well, so that we can direct it and use it for our medical purposes. But it has very dangerous properties, so you need to realize that it's a hazardous thing, but you have to handle it carefully. Okay. It's very useful, but it's dangerous because it's a coherent, collimated, and monochromatic wave. Both direct and reflected beams are potentially dangerous. Okay, not only direct but reflected things. Beams are also dangerous. And the other thing is, you can see the visible range, but ultraviolet and infrared range you can't see. By the time you realize, the damage is already done. So that's why it's dangerous. So what are the dangerous sites? So it is danger to eye. It can cause burns and ignition. Okay. Depending on where you are going to use it. So therefore, there are limits you can use it, and then there are regulation for laser use. So basically, it is classified according to the maximum permeable exposure levels, okay, and effects on the eye and skin. These calculations done by International Electrotechnological Commission, IEC, standardization. It gives all sorts of electrical regulations for electromagnetic machines, even for your anesthetic machine. There are IEC regulations. Syringe pumps, there are IEC regulations. So all sorts of machines, they give the regulation. So as for the lasers, they give standards 60825/1. This is produced in somewhere around 2007. So it gives 7 categories, 1 to 4. There are subcategories in middle 2 and 3. So altogether there are 7 categories. Medical laser comes in category 4 in highest risk category. Okay. That's why it's you have to be very careful when you use laser, although it is very useful. So we'll come to what are the anesthetic related risks in regards to laser. Okay? The injury related to laser may be deaths are associated with upper airway surgeries, where ENT surgeries or mainly the throat surgeries, they use laser. Okay, and this can be hazardous to patients and the staff, and then the environment, the theater. What are the effects? So problem with equipment, if you take, because laser is an energy medium, and I think you may have learned about fire and explosion. There are 3 things you need to ignite fire. Okay, so you got ET tube as a the material. Oxygen is there in the airway because we are supplying it through the ET tube. And then if you direct laser, which is a source of energy, to increase the temperature to appropriate level so that it can ignite. That's the danger. Therefore, we need to avoid normal ET tubes. Or if you are using ideally it should be a non-metallic, the tubes should be laser resistant tubes. Okay, either it's a material which does not ignite, or you can cover a normal ET tube with a non-reflecting tape, okay, which taped around the ET tube, so that it does not reflect and it does not absorb the energy to ignite. Okay, the other thing is that the laser can damage your cuff in the tube. So what happens is, if you don't know and the cuff is burst, your anesthetic gases going to leak into the surgical site. You know, some of the anesthetic gases can ignite, and then there may be fire inside your airway. Okay, so when we do laser surgeries in throat, we tend to use minimum of amount of oxygen, right? And we don't use nitrous oxide, which can be a combustible gas. Okay. To overcome this cuff burst, either you can use a double cuff, or sometimes they use a methylene blue inside the cuff so that you know when the cuff is burst because of the color of methylene blue. Okay. So those are the things you can do to avoid endotracheal tube, to avoid any fires due to endotracheal tube and laser. Then the other thing is that you need to avoid combustible drapes, which help to ignite. And you need to avoid spirit-based cleaning solutions, where it can help to ignite fires. If you have to use it for cleaning, you need to wait till it evaporates before you start laser. Because patient is under anesthesia, even though you use visible light, you need to cover the eyes and the skin of the patient, because inadvertently you can burn the patient's eye or retina or skin. So therefore you need to cover eyes of the patient and then skin of the patient. Okay. So theater safety. If you are using a theater, there should be a proper pre-planned theater safety program in place if you are using a laser inside the theater. There should be a laser safety advisor who looks after the safety aspect of this theater and the use of laser. All personnel should be adequately trained in handling equipment and protective strategies in laser. And hazard classification of the laser, which type of laser you're using and which classification of risk in that particular laser belongs to, should be marked on that laser generating equipment, and regular servicing of that equipment is mandatory. It will help you to minimize the risk if you use a maintain a logbook of use of laser, so you can trace. So there should be a designated laser theater if you are going to use it, and there should be a windows and doors should be able to close when you are using laser, and there should be a display where when you are operating the laser, there should be a display on outside that at that moment they are using the laser inside, so nobody is allowed to come in during use of laser. So inside theater personnel, all theater personnel should use protective eyewear, goggles. Spectacles are not acceptable. So it's a proper goggles should be there, because reflective laser beams can come from any direction and burn your eye. There should be a non-water based fire extinguisher available in the clinical area of that theater if there is a fire inside the theater. Okay. So all these safety precautions should be accomplished before you go into use laser. In spite of that, if you have a fire during a surgery, in say throat surgery in a ENT, if you have a fire, what are you going to do? So triad is fuel, oxidizing agent and heat. You have to remove this. Okay. So you need to discontinue laser surgery. Make sure surgeon is aware, anesthetist is aware. They should have a good communication. You need to stop ventilation. Okay. So you need to give oxygen. You need to stop oxygen supply, right? Because it will continue to burn if you continue to supply oxygen. If you have a burnt ET tube, you need to remove that, because otherwise the patient's airway will be burned further. So you can put water, cold water, if it is inside your airway, you can put cold water depending on, I mean, you have to be careful with volume you are going to inflate, but you can put water to, lower the temperature so that it will prevent further burning. So you can once you have controlled the burn or fire, you can restart ventilation with a self-inflating bag or ambu bag. And then further, once you got control, you can re-intubate the patient and ventilate with room air. And ENT surgeon has, once you re-intubate, ENT surgeon has to put a rigid bronchoscope. Once you have got control over the situation, he has to examine the airway for thermal injuries and remove any foreign bodies if there's any debris or anything like that. You may have to keep the tube, most likely, or you may have to do a tracheostomy. And patient has to be cared in the ITU, and you may have to give hydrocortisone or steroids to prevent further inflammation. And you may have to start antibiotics for this patient, because patient can have necrotic tissue and it can get infected. So it's a worst kind of scenario if you have a fire. But you should be able to tackle that, and you should be prepared to do that, and you should be aware of it, that the fire can occur if you are using a laser in throat surgery. This is commonly happen, not commonly, I mean, this can happen in throat surgeries because they can remove lesions in vocal cords, tumors in ablate tumors in airway using laser. So they can use laser in throat surgeries. In eye surgeries, they use laser, but the fire is not that common in eye surgeries. But patient can have burns if you're using inadvertently. Okay. So that's about it. Laser. So there are some articles, especially there are 2 articles in BJ Education, and there is another one in what you call weekly anesthesia tutorial by World Federation of Anesthetists. You can Google it and it's free, available free. So those are good article. And then you got Pabrook as well with the basic physics about lasers. Yeah, those are the references which I referred. So any questions regarding laser? No? Are you there? Are you too tired? Can you hear me at least?
Yes, sir.
So any questions? So I guess they can ask MCQs. You can prepare MCQs. I can see even I can prepare some MCQs from laser. And you can get Viva questions from laser. You got OSCEs now, isn't it? For part 1. Hello? Are you there? So I think you got OSCEs now, so they can ask you the safety mechanisms on OSCE kind of thing from laser. So those are the questions you can ask for the physics, I think this was. Okay, shall we have a 5 minutes break or you want to carry on? We'll have a 5 minutes break. I'll have something to drink and say what's the time. From now on, my time is different, so I will start in about 5 minutes time. Okay, with ultrasound. Just stand up and just move around a little bit so that you get some blood supply to your limbs and probably improve your blood supply to your brain as well. Okay. Yeah. In 5 minutes, okay? Okay. Can you hear me? I'm going to share my second presentation. So there's a question in regards to laser. So it asks, the question is, what is the relationship between effect of laser and the frequency of waves? So as far as I know, the frequency, it's electromagnetic radiation. So the frequency affects the depth of penetration, basically, of laser beam. So if you have a, say, the frequency, if you relate it to the wavelength, if you have a high frequency, the wavelength is short. Wavelength is short. Okay. So short wavelength means your penetration is less. Okay. So because of that, your laser beam, if you have a low wavelength, right, then your penetration of tissue is less, and you have to use it in a superficial structures. That's what I know as far as my knowledge. So if you have a larger wavelength, your frequency is less, and then your penetration is more. So you can use that beam to penetrate through to a deeper tissues and use it to cut or coagulate deeper tissues. Okay, that's that. So can you see my presentation?
Yes.
Okay, good. So this is basic principles of ultrasound and WG. So as far as basic physics concerned, first part is applicable. Second part we will go through if the time permits. Okay. So as I said, under the physics of ultrasound, I will talk about generation of ultrasound beam, interaction with acoustic tissue, interaction of acoustic waveform with the tissues, how the image is built up, and then how to adjust the image quality depending on the basic principles, and what are the modes of ultrasound scans and types of transducers. Okay. The other one is a bit more practical stuff, so we'll see how it goes. So first of all, it's a mechanical energy source, and it's a sound wave in high frequency, so it's called ultrasound. So because of it's a sound wave, it needs a medium. Okay, and it's a pockets of pressure waves, basically. Okay, so it's kind of pressures and relaxations. So because of this waveform, you have a number of cycles per time unit. So you have a frequency. All right. So human can hear about 20,000 hertz, but more than 20,000 ultrasound. So commercially available ultrasound use is in megahertz range. Okay. So as I said, it's a sound wave. You need a medium to propagate, whereas electromagnetic radiation, as in laser, does not need. Okay. So diagrammatically, it will be like this. Okay, the generator, relaxation, compressions, relaxation, compressions. Okay, and this is a kind of a sound wave. And how we hear a sound, what how you can hear is what I'm talking is like this. But there's an intermediate part where electromagnetic waveform is taken over. And then again, from your speaker, you can hear as this sound waves. Okay. So basic nomenclature, if there is a wavelength, so distance of one cycle, and there is a frequency, number of cycles per unit, and there is amplitude or volume, higher the amplitude, higher the volume, and there is a velocity of sound can go, okay, or speed of its propagation. So what are the factors which determine the acoustic velocity? It depends on the density of the medium and the compressibility, okay, and the bulk modulus. So interaction of this waveform with the tissues, what can happen to this waveform, ultrasound waveform, okay? There are several things. It can be either reflection, it can be refracted, scattered, diffracted, or interference or absorption. These things can happen to your ultrasound beam in the tissues or the medium, because it has to go through a medium to propagate. So reflection, what is reflection? As in light, this is more, it's similar to light, okay? So when you direct a ultrasound signal onto a surface in an angle to an incident, there is a reflection back equal to an incident angle, okay? So you can see as in light, if you direct this like that, and then it will go up like that. So don't I get a point? Yeah. So you direct it like that, it will reflect it back like that. These angles are same. Okay, this is called a specular reflection. This is same as in light. So how it works in ultrasound is that, so you've got a ultrasound probe here, and this is the emitting area of the ultrasound, or say this is blue is the ultrasound, this is the gel part, and this is the tissue. So you got a medium. Why there is a gel? You need to have a proper medium in between your surface of the surface, okay, and the ultrasound beam. You need a gel here. Otherwise, if you have pockets of air, the ultrasound doesn't penetrate through. So you need a medium. So you put some medium, usually gel or saline would do. And it's emitted, and then there's a surface in between this gel and the tissue where it gets reflected, okay? So, and then part reflected and other part is penetrated to a second interface with two tissues, tissue 1, tissue 2, right? So there's an interface, tissue interface. So what happens there is that it get reflected. Percentage of what it comes is reflected back, okay? Not all, percentage depends on the tissue interface, how much is get reflected. So this reflected back ultrasound beam is detected by this same probe. Now we will talk about how it generates, how it received later on. So this is detected by the probe, and then it is converted to electrical energy, and it's processed and shown in your monitor. So that's reflection, okay? What happens if you if your beam is put on directed on angle of a tissue, so it is reflected back like that. So if you don't have anything coming back to your probe, as in this, you can't see that surface, basically. All right. So something has to come back to your transducer to visualize that surface. So what happens is these ultrasound beams emit throughout this whole range. So it is number of ultrasound beams are emitted like that, and this is get reflected, and some will come back and some will go away from the probe. So whatever which are away from the probe won't be registered in your probe, and it will not come to your monitor. But whichever you are getting back will be registered or in the ultrasound probe and reflected on your monitor. So it's depend. That's why it depends on your angle also. Right? So these surfaces can be identified by the ultrasound. Okay. So what determines this reflection? It determines by the how much it is reflected, and how much it is reflected or percentage reflectivity can be calculated by this equation. Okay. And it's called acoustic impedance. It depends on acoustic impedance, and then how much it is reflected will determine how you can see the tissues, whether you can see beyond that surface or not is determined by percentage of reflectivity. So for example, if you have a tissue-bone interface, okay, 43% is reflected, but 57% is transmission through to the bone. Okay. So you can, this 43%, which is reflected back to your probe, okay, generates the the periosteum of the bone. And whatever this 57% transmission, we'll talk about later what will happen to it. Okay. If you take, but because of this 43% reflection, you can see the periosteum nicely with a sharp edge. So if you get tissue air interface, like in pleura, for instance, the Sorry about the technical issue. There was a technical issue, was disconnected. Let me share my presentation again. Sorry about that again. So let me go back to. Yeah. Can you see my presentation?
Yes, sir.
Okay. We'll restart what. So we were talking about here. So in the bone, soft tissue bone interface, 43% is reflected, and rest of the 57% is transmitted through to the bone. So this 43% produces this periosteum, sharp edge of the bone margin. Okay, if you're visualizing chest, you can see the ribs as sharp lining, edge of the rib, and then below, down that edge, you can't see anything. It's black. We will explain why it. So it's already there. So this, although 43% is reflected, the other 57% is absorbed by the bone. That's why you can't see anything beyond the rib. Okay. So you can see only the surface or outer surface of the rib because it's reflected 43%. And whichever gone through is absorbed by the bone and it doesn't reflect. So that's why you can't see anything beyond the bone. So what about soft tissue air interface? So as in lung, which is lung is full of air. So on that surface, soft tissue lung interface, almost 99% is reflected back. Okay, so everything is reflected back, nothing is transmitted. So if you don't have any ultrasound going through that tissue, you can't see beyond that tissue. It can be reflected back on the next interface, tissue interface. So if almost everything is get reflected at the proximal surface, right? Nothing goes beyond. Therefore, nothing coming back beyond that point. So therefore, you can't see, right? So that's why your lung, pleura, you can see as a sharp edge or white margin as everything is get reflected. And beyond that point, it's black in a normal lung, okay? The story is different if you have a collapsed or consolidated lung because it's not air inside collapsed or consolidated lung, okay? So these are the percentage of reflection. Can you see? Air, soft tissue, almost 99.9% is reflected. How about fat and soft tissue? It's very, very less amount reflected. Water and soft tissue, reasonably amount, although it's less than 1%, but it gets reflected. Bone and soft tissue, 43% is getting reflected. Okay, so all depends on how much the tissue interface can reflect and how much it can transmit. Okay, so for example, this is how you can see the liver, and this is the lung margin underneath. So liver can transmit. This is soft tissue. This is the one surface, outer surface or proximal surface of liver and the soft tissue. This gets partially reflected and partially transmitted. So the waves go down like that, and then you have the liver lung interface where almost everything gets reflected. So here you don't get anything, it's almost black. These are white vertical lines, these are called B lines. You will know when you learn about ultrasound. So those are artifacts basically. Those are not real images. So we can interpret those differently. So this is nothing is transmitted, therefore we can't see anything. This is so sharp because everything gets reflected. Okay. So reflection and transmission happens like this. So this is the skin transducer interface, and then you go down. This is the first interface, and then partially get reflected and coming back to the transducer, and then rest is transmitted, and then second interface, its percentages get reflected and rest transmitted down to the next level. So each and every tissue interface will get reflected. So those are coming back to the transducer, and which is registered. This is how the basics of ultrasound we can see. Okay, so once there's nothing going through or transmitted, then beyond that point you can't see any more images. Okay, so you need to adjust your depth, gain. There are some adjustments you need to do. So type of reflections, there are two types. Basically, smooth surfaces can have a specular reflection, so it will come back to the transducer, and irregular surfaces causes non-specular reflection. Basically, it will scatter. So irregular surfaces you can't see as a sharp margin. Okay. So refraction, this is another thing which can mimic light. So when you have two interfaces with different densities, in the light, according to the Snell's law, if your density is higher on this side, second tissue, this beam get refracted towards the normal incident, right? So this angle is more than this angle, right? So this comes at this, it should go like that, but it is bent like this towards the midline or perpendicular line if the density is higher on this tissue rather than this one. So that's called refraction. This is according to the Snell's law. So basically this density can be replaced by the velocity. So if you have two media with two different velocities of ultrasound, so first media has a higher velocity than the second media, it will reflect towards the normal or midline or perpendicular line. If the second media velocity is higher than the first media, it will reflects away from the perpendicular line. Okay, so that's why this kind of picture comes. This dark shadows behind this cyst is because of that, the refraction of this, because this is a cyst with water-filled cyst, right? Because of the refraction, this dark areas occurs, and this is enhanced, okay, because of the refraction. This is a kind of a stone inside this cyst. Say it's a gallbladder. This is a gallstone where it blocks, it's filled with calcium. Then it absorbs ultrasound. So behind that, there's a black shadow. Okay. One other thing it does is refraction, is that because of your bending at the interface, it should have been gone like this, but it is refracted. So actually these images from this object comes like this, and it is bent like that. But this ultrasound thinks that it is coming from here. So it's misregistered as it coming from here. So in clinical practice, what will happen is that if you get iota like that, sometimes you can, because of these two beams, one is refracted and one is straight away, this one is refracted, you will have a kind of a pseudo image like that. That's the effect of the refraction. So diffraction is called divergence. So although we assume that ultrasound beams go parallel for a long distance, but once it's go some distance, it tends to dissipate or spreads out. Okay. Because of that, your density of the ultrasound beams less and less once it goes further, especially with the curvilinear probe like that. You have seen that curvilinear probes like that. So beams are like that. So your density here is different from density there. So it's because it's spanned like that. So your lateral resolution is get affected when you go further away from the probe. Okay. Then you got interference. So there are two types of interference to your ultrasound beam. So one is constructive interference, where algebraic summation occurs if the waves are in phase. Okay, so its amplitude increases like that. So if you have one ultrasound beam overlaps with the other one, this area, the amplitude increases. Your strength of signal this area, you may have a destructive phase because your destructive area where you can't visualize properly because your ultrasound beams are not in phase. Okay, so this will affect your clarity of your ultrasound pictures. The absorption. Remember, we talk about bone. The periosteum can be seen as a sharp edge, but beyond that point, you can to transmit. But all of this 57%, most of it is absorbed by the bone. Okay, so nothing is reflected beyond this point. So then what happens is not in bone, other tissues can absorb the ultrasound, which can use as a therapeutic to heal tissues. So what factors determine how much is absorbed depending on the viscosity of the tissue, or viscosity or density of the tissue, or the frequency of the beam, okay, and the relaxation time. So the attenuation. What is attenuation is when you go further away from the probe, your strength of your ultrasound beam reduces, okay. This is because of the tissue absorption of the ultrasound and the scatter, or the because it's divergence, the ultrasound beams diverge, so the density is reduced. So this will determine the depth of penetration of ultrasound. Okay. So basically, the absorption, as I said earlier, determines by the frequency. So basically, is absorption determines therefore attenuation, and attenuation increases when the attenuation increases, when the frequency increases, attenuation increases, and then the depth of penetration reduces. Okay. So how to overcome this? You can do a few maneuvers. There are things called, you can increase the gain or emitted ultrasound strength can be increased in a particular area. So this is called time gain compensation. So you can increase the beam strength emitted by the probe so that you can have the reflected back ultrasound beams also much higher strength. Or you can amplify returning ultrasound beams or reflected beams can be amplified by the transducer so that you can visualize in more detail. Okay. So for example, on your picture on your left side, you can't see this area, but on the right side, you can see this depth because you see the difference in the frequency, all right? And then your depth, okay? They have increased the gain and time gain compensation so that you can you increase the gain, you emit more high strength ultrasound beam, and you amplify the returning ultrasound beam so that you can visualize more depth structures. Other thing you can do is a focus. We will talk about it later. So attenuation coefficient is the other thing. Depending on the tissue, how much getting attenuated. So see the difference. Water attenuates very much less. So, but compared to that, bone attenuate more than, say, probably 5,000 times. So you can't see beyond bone, but water can be used as a medium to enhance the visualization of the ultrasound so that you feel the bladder with say urine, which is kind of water-based, so that you can visualize deeper structures than the bladder. So that's how it attenuates, okay? So this is a cyst, water field cyst. Can you see the attenuation? Enhancement because of the less attenuation by the water and compared to the surrounding tissues where this area is, when you go down, same length, because these are emitted in the same way, parallel. This area is darker compared to this area where this water, because less attenuation happens compared to this area and this area. So these are reflected more. Okay, that's called posterior acoustic attenuation. So how do you improve the quality depending on the, okay. So how do you generate ultrasound beams? So firstly, this is the probe of the transducer, which has a piezoelectric crystals like that. And then you got a cable which is connected to a current, pulsatile current, electric energy. What happens is that when you energize, give energy to piezoelectric crystal, it vibrates, vibrates in a particular frequency. You can adjust the frequency depending on your requirement. When it emits ultrasound through there. So there's a lens kind of thing where you can direct this beam towards a point or area where you want to have these ultrasound beams. Okay, so this is the energy, electrical energy coming to the transducer, and this is the piezoelectric crystals, layer of piezoelectric, not only one, it's a multiple layer of piezoelectric crystals, which vibrates and produce this ultrasound, and this acoustic lens directed towards whatever area we want to have, okay? So then this ultrasound is directed, say this is an interface, and it gets reflected back to this ultrasound probe, and then this ultrasound transducer emits ultrasounds in pulsatile manner, because it emits and it waits for or pause for some time till these reflected beams comes back. Okay, what happens is that there is a series of piezoelectric crystals along this transducer. So it starts emitting like that, switch on, switch off, switch on, switch off. So it goes like that, emitting ultrasound in parallel like that. And once it is, these are switching on, these are on the receiving mode. These are on the emitting mode. And then it goes back like that. So say 1 millisecond, one piezoelectric crystal is in emitting mode, and then it switch on to a receiving mode for another, say 5-6 milliseconds, and then again it can start to emit. So it's kind of a serial emission of ultrasound along these crystals, emitting ultrasound like that and waiting to receive return signals to its piezoelectric. So it's a transducer, so which receives ultrasound and then it converts back into the electrical energy and goes, as in this cable, to process and produce as a ultrasound image. All right, that's what happened. Okay, so how do you adjust the image quality? So you can either increase the gain. That means you increase the energy supply to the piezoelectric crystal, which will vibrate more, not rapidly, same frequency, but more with more amplitude, so that your volume, or say energy, is more in ultrasound beams. So that the reflected energy from the surface is also higher. Then you can adjust the depth. So the visualization depth you can target, and then you can adjust the focus of the beam using different lenses on your transducer, so that your beam can be focused on a particular depth. Say you want to focus a depth of 5 centimeters from the surface, you can focus that 4 to 5 centimeter range of depth. What it does is that it increases the ultrasound density on that region, so that you have more dense ultrasound beam, and more you get more. If you target more ultrasound beams, you get more reflection, so that you increase the image quality. Okay. So this is what I explained. This modulate the voltage to the crystal and produce an acoustic pulse of variable intensity, all right, and increase the receiving gain. So this is a time gain compensation. Probably if you have handled an ultrasound beam, you've got one button where you can increase your gain globally, or you can increase your gain in several layers of your ultrasound picture. Okay, then the depth, you can say, if you want to see the level of aorta, which is probably about 15 to 20 centimeter depth, or say kidneys, which is about 10 to 15 centimeter depth in an average built man, you can target that depth. So if you want to visualize the depth at that level, no point in having a depth of 30 centimeters. For example, so you need to select, if you want to target a particular depth, you need to select appropriate frequent transducer because your transducers differ in frequency, right? I will talk about different transducers later. So because when the frequency increases, depth decreases. So if you want to visualize a deeper structure, you need to choose a transducer where it has a less frequency so that you can have a deep penetration to visualize. Okay. I don't think you need to know. So two types of resolution. So one is axial resolution and then lateral resolution. Okay. In ultrasound, axial resolution means, say, there are 2 points like that in vertical axis. How the clarity of those 2 points you can visualize in a vertical axis. That's called axial resolution. So if you increase the frequency, your axial resolution is better. And then what happens is this lateral frequency is the lateral resolution is that you can see whether this area you're much more clearer than this lateral areas. That's called lateral resolution, because when the ultrasound beam diverge like that, your resolution is reduced on lateral sides. Okay, that's lateral resolution, right? Axial and lateral. Then the focusing, what I told is that if you want to focus this area, what it does is there's another knob you can focus. So say this depth is about 15 centimeter. This is the transducer which targeted this area so that the ultrasound density is higher at this area, so that it has more ultrasounds focus on that area, so that the reflected beams are much stronger, so that you can see more clearly on that area. Okay, so this area will be more clearer than this and this area. Okay, see now this picture, you can see this heart is not that brilliant. You know, picture is not, the clarity is not enough, but this is because of the focus. This is the focus area of this picture, and this is the focus area on this picture, this range. So when you target the focus area to whatever the target organ you want to visualize, your image quality improves because of your ultrasound density is high at that area. Then we come to, those are the properties of ultrasound and how you use it to your advantage to clarify the image. Then you need to know a bit about some modes of ultrasound we use. So basically there are A modes, B mode, N mode, and Doppler mode. Okay. What A mode means is the amplitude mode. You won't find this mode in your ultrasound currently because it's a historical mode. All right. So what it does is, it's this amplitude mode, it produces this kind of a point like that graph on that depth. This is the depth and this is signal. Okay. So image is plot of amplitude and time. It's a graph basically. So it doesn't give you that much of detail in A mode. So that's why we are not using that mode now. So if you examine ultrasound machine currently, you won't get that mode. So the B mode is brightness mode. Okay. So what this brightness mode does is, if you keep ultrasound probe like that across the body like that, so you got this reflective surface, this reflective surface, this, and this on this line. So it will be reflected like that. All right. So this is one beam basically, and it will give you a dots like that. A mode will be like this. B mode will be like this. Okay. Does it make a sense? Because you can't see, and then if you move the probe like that there in this direction, so you can see whatever the structures on there, and it will be reflected like this on here. Doesn't make a sense, isn't it? So what they did was, they tried to sequentially fire series of piezoelectric crystals attached to this transducer end like that. So it will fire sequentially like that. Okay. So for example, if this is the ultrasound probe, okay, my finger edges. So it will start sequentially. These are all piezoelectric crystals, right? So it will start firing, say, let me see. So this is the, oops, sorry. Let me see. Can you see that? Yeah. So this is the transducer surface. So there are several piezoelectric crystals along this border. So it will sequentially fire from here downwards like that. Fire and go to receiving mode. Fire, receiving mode. Fire, go to receiving mode like that. Sequentially, it will fire continuously like that. Okay. So real-time scanning, which we use B mode now, is a real-time scanning. So it will sequentially fire along the crystals or along the edge of the transducer, so that it will sequentially continually firing like that and scanning toward like that. So it will continuously update your picture. So you can't see dot appearing and disappearing because it happens more faster than updating or registering in your mind. So, can you follow me? So images is continuously formed as beam is swept across the field of view. Only objects in the scan line are depicted any given moment. But it happens so fast, these multiple dots recreated so that you can see even movement. Because your eye is not so fast to understand that these are dots which is appearing and disappearing. Okay. But it's a two-dimensional picture. Okay. Can you appreciate that? You got a picture on an ultrasound, but your body is like that. Okay. Your body is like that. You cut across the body at a particular area in a straight line, and the structures along that line, or like that, okay, it's a line like that, or like that, which is emitting ultrasound. So whichever the surface interface which cuts and reflects will give you a dot. Okay, and it's a two-dimensional picture it creates on your screen. Okay, so it's not a three-dimensional. But later on, computers can regenerate three-dimensional things, but it's too complicated. We will keep it simple, right? So it will be a real scan B mode, sequentially emitting piezoelectric crystals, receiving reflected beam, and producing multiple dots in your kind of what you call monitor, which creates a continuous moving picture, so that you can appreciate lung sliding in lung ultrasound, or you can visualize breathing or movement of the diaphragm. You can visualize pulsating aorta. All those things you can visualize because it's a continuously firing piezoelectric crystals in the beam mode. Okay. So how fast these images recreate, it's depend on the scan timing, a depth of your structure, and the scan line. Those kind of technical stuff will determine how fast these things are recreated, and depending on that, your clarity will determine, your picture clarity will determine on these technical features. Okay. So then the other mode is the M mode, which is called motion mode. So I don't know whether you have seen a picture of a motion mode. So when you press the button M mode, what will happen is it will select one line of your picture. Say this is the B mode picture, right? Continuously firing this electric material, and it will select this line, and so it will detect movement along this line, tissue interfaces movements, like say this interface movement, this interface movement, this interface movement along the time. So this is along the time, and these are the tissue interfaces. This is at this level, this is probably at this level, this is probably at this level, and this is at this level. So these tissue interfaces movements will be depicted or represented by this shiny line or lines along the time axis. So on other words, it will select one particular point along your 2D image, and it will give you movements of all the surfaces or interfaces along the time. And you can see the movement so that you can freeze it and measure these differences. Say this is a left ventricle cavity on a short axis. You have cut the heart in a horizontal manner, and in systole this will come to this size, and diastole it is relaxing. So if it is contracting, your distance between two opposing walls will be shorter, and in relaxation or diastole it will be more away, right? So you can measure these two distances over a period of time, right? So that's how you use M mode. Okay, it's over a time period. Your surfaces movements can be graphed in an ultrasound. Okay, so basically it's used to observe movement of the structures plotted over a time scale. Then we will talk about the Doppler mode later on. Then there are several types of transducers. These are the common transducers we use in theater and ICU. So you've got linear array probe, curvilinear probe, and then the pulse array probe. Okay, just brief introduction. So this is the linear probe. You've got this linear surface on your linear probe, and then you've got multiple piezoelectric elements or crystals along this straight line, which emit sequentially, as I said earlier. And then they received reflected beams. The special thing about this is the emitted frequency of this ultrasound beams are 12 to 15 megahertz. Because of its shape, it's mostly non-divergent beam is parallel beam is emitted. All right. So because of its high frequency, relatively high frequency, its penetration is low. Therefore, you can't scan deeper structures on with this probe. Okay, so probably up to 5 centimeters is the max. So the picture will be like this. The yellow arrows are the ultrasound beams. So this is near end. This is a far end. This is about 3 centimeter depth. So you can visualize this. This is probably these two artery and vein on a, say, radial artery and vein on the wrist, like that. So this is how you can see it. Okay. So curvilinear probe is the other one. So there is a curvilinear surface where the multiple piezoelectric crystals are placed alone here, and these are emitting sequentially. So only thing is now, because it's fan shape, it emits like beams emits like that, and it has frequency. It emits ultrasound beams in a frequency of less than 5. So it's a very low frequency. Because we know that low frequency beams can penetrate more because the attenuation is low. So it can be used to visualize deeper structures like, kidneys, aorta, IVC, like that. So it can be used. So this is the kind of picture you can see. So this is the possibly kidney looks like. This is the liver. So this is how the ultrasound beams emit fan shape. Okay. And a curvilinear probe. So phase array probe, it's a 2-dimensional array probe. Piezoelectric crystals along this slightly linear, but we will see the picture next slide. So basically, important is that it's the distance between these two ends are very small, so you can keep in a small window. Okay. So it also has a diverging beam, right? But only thing is, curvilinear probe has a more wider surface, but this has a kind of a mini narrow surface, so that you can keep in between two narrow ribs here and emit these beams in between those intercostal space, so that you can see structures underneath the ribs. Basically, we use this for the cardiac imaging. So the heart can be visualized in between two ribs through the intercostal spaces. But there is a lateral resolution issues on this one because it's divergence. This can penetrate quite far. This frequency is somewhere around 5 megahertz. So it can penetrate through. So we come into Doppler now. So what's Doppler? So the principle is that when you shoot or aim your ultrasound beam in a particular frequency to a moving object, the reflected back ultrasound beam's frequency changes. Okay. I'm repeating again. If you aim an ultrasound beam to a moving object, the reflected back ultrasound beam frequency is changed. So if your object is moving towards the ultrasound beam, towards the probe or emitting, say your ultrasound is like that, and your target object, moving object is moving towards your ultrasound. then the reflected frequency will be increased. But if it is going away from your ultrasound beam, the frequency will be decreased. All right. There is a equation, frequency shift equation, okay, where F is the frequency of emitting ultrasound beam. This is the velocity of the beam, and this is the velocity of the ultrasound beam. Velocity of the moving object is V. Velocity of your ultrasound beam is C, and the angle you emit this ultrasound is the alpha. So the equation is like this. Sorry. Doppler frequency shift is to viscosity of the, if you are emitting it towards a bloodstream, right? So viscosity of the blood, sorry, velocity of the blood and velocity of the ultrasound beam, okay? So this is the Doppler frequency. This can be asked in the Viva or tested at any level. Okay, 2 into velocity of the beam, velocity of the blood, velocity of the beam to cos theta. Theta is this angle. You can imagine if you keep it at 90 degrees, this cos theta becomes 0. So you can't have any frequency change. Okay. So if they ask at what angle the frequency change not happening, it is at the angle of 90 degrees to the movement of the target organ or structure. Okay. So this can be used to visualize in surgery and anesthesia. This can be used to visualize blood flow, basically in the vessels. So in surgery, they use this as a Doppler ultrasound, basically sound, to triple sound, like to have whether they have a blood flow in the arteries, and then we use it in critical care in B mode. If you add you can add this Doppler on top of the mode, okay, and then whatever towards your probe is visualizing as color Doppler as red, whatever going away from your transducer visualize as blue. Okay, it's not artery and vein. Whatever towards you or probe is red, whatever away from your probe is blue. So that's how you recognize the direction of flow. Okay. So you got, this is a color Doppler picture, kind of picture you get. So this is an artery where your probe is here. So flow towards your probe, and these blue dots are away from the probes. This is color Doppler, right? So it gives you basically direction of flow. Okay, it doesn't give you any number. But if you want to have a flow number, you need to have a pulse wave Doppler, so that you can measure actual velocity like that. So it gives you a time versus velocity graph. Okay, but you need to keep it an reasonable angle so that it can calculate these velocities. So it will automatically calculate your velocities of blood flow, and you can use it for different purposes to see whether your flow is adequate. This can be used to measure the cardiac output in left ventricular output tract, or you can use it to measure the flow in your brain, flow in your carotids. So depending on your flow, you can, depending on the clinical situation, you can have different interpretations. So this is a very useful kind of measurement you can get. So Doppler, you have a color Doppler, pulse wave Doppler. Color Doppler, it gives the direction only. Pulse wave Doppler, it gives a velocity number as well. Okay. Power Doppler is basically it enhances the Doppler so that it gives only there is a flow, because sometimes with the minimal flow or you can't see the color. So power Doppler will give you a kind of a flow. It doesn't say any direction or number wise any velocities. So basically those are the things I wanted to tell you. This is kind of a practical aspect. So let me see. So you got an ultrasound machine. You can do a depth to that adjustments using buttons. This is the gain adjustment buttons. These are the mode adjustment or select buttons. So you got B mode, okay, and this is M mode, all right, and then you got power Doppler, color, pulse wave Doppler. Okay. Yeah, that's about it. So ultrasound, in summary, ultrasound is a sound wave. It does need a medium to travel, and there are physical principles which govern its travel. And then ultrasound is created by surface interface reflections in every surface. So some surfaces reflect different surfaces, surface interfaces reflect different percentage of ultrasounds, so that some you can see very well, some you can't see very well. And then you need to have a reflected ultrasound beams to be visualized that interface. Okay. Then you got different adjustment to increase the image quality, and then you got different types of probes available to suit your different purposes, maybe the depth or the clarity, because your linear probe, which is more superficial, but it gives more clarity than the deeper curvilinear probe, okay, because of the density it has. And then interference can come with different things, like reflection, and then enhancement of the different tissues, give you different interference to your ultrasound. You need to interpret more carefully your pictures, because otherwise you will be fooled by the ultrasound picture. And you got different modes. Currently we use B mode or brightness mode, which is a 2D image, then motion mode, in mode which gives you the movement along the time frame, and then you got Doppler mode, where you can visualize moving targets. If it is color Doppler, it will give a direction. If it is a pulse wave Doppler, it will give the velocity numbers as well, as well as the direction. And then of course different techniques you can enhance. Okay, that's about it basically. Doppler maximum signal. There's a question, Doppler maximum signal when probe is 90 degrees. Is this correct now? Because cos theta, that equation contains cos theta. Cos theta, when that angle becomes 90, the whole cos theta becomes 0. So there's no signal at that time, because 0 signal or 0 frequency change. There's no frequency change at all when it is 90 degrees, probe is at 90 degrees. Any other questions? Any comments? Anything? Did you understand?